to invite the next speaker, Dr. KVS Harikumar sir. Dr. KVS Harikumar sir is consultant endocrinologist at Magna Clinics and Fernandez Hospitals, Hyderabad, and is also the Honorable Secretary, Endocrine Society of India. Warm welcome to you, sir.
Thank you, Dr. Lakshmi, and good morning, everybody. Before the presentation comes, how many have used Myoinositol in the management of PCOS? Can you just raise hand? Okay, plenty, very good. How many haven't heard about Myoinositol till now? Can you raise a hand? Okay, thank you, ma'am. Very good. 2, 3 more.
Sorry, heard.
Okay. So my job is more of a simple interaction about where you place this so-called nutraceutical, chemical, drug, all put together in one basket, where to use it in the PCOS. I will explain under the following headings. Couple of slides about insulin resistance, because that is what is the key factor in which it is going to be addressed, and some of the studies which quoted this in the management of PCOS. PCOS is the most common endocrine disorder in the young, middle-aged ladies, so there is no doubt about it, and insulin resistance is the key factor underlying. You all know about the spectrum or the phenotypes of PCOS, A, B, C, D. The D is the only one which is important, where there is no hyperandrogenism in it. Rest of all three will have hyperandrogenism. If you look at, I don't know whether you can see it, nevertheless, doesn't matter. Insulin resistance drives PCOS, because if you have higher insulin, your FSH gets deranged, your LH pulsatility gets deranged, your androgen production increases, all those things. And on the other hand, if you have hyperandrogenemia, that also will contribute to the insulin resistance and PCOS. So important is both will work simultaneously and propagate each other to worsen the underlying condition. Which comes first, nobody knows, but you need to address that without any problem. That is underlying, that is most important to understand. Now, spectrum of PCOS is wide. Somebody comes with irregular menses, somebody comes with acne, somebody comes with difficulty to conceive, all those things. So it's a different spectrum which you all handle, and the management obviously will suit to the person who is coming to you with the particular complaint. It is not that PCOS as a basket will receive XYZ treatment. There is nothing like that. Depending on what is the complaint, depending on what is the primary problem at that particular point of time, you need to tailor your therapy. Here I am only going to concentrate on the insulin sensitizer, because my topic is of inositol. Okay? Insulin sensitizers conventionally use metformin. There is no doubt about it. Enough experience, enough evidence, part of some guidelines as far as usage or benefit in the metabolic parameters and glycemic parameters. Reproductive outcomes and other things, it is not robust evidence. Some people use it. It is more of a I would say convenience based. But as far as evidence is concerned, more robust is only as far as the metabolic and glycemic outcomes. The other two, the thiazolidinediones and GLP-1 RAs, are not commonly used for reducing the insulin resistance in the PCOS, but nevertheless there are enough studies in that. The last one is the inositols. You can see some of the outcomes, what they do as far as the different outcomes in the different settings are concerned. Menstruation, ovulation rate and hyperandrogenism, and glucose, body weight, and you have the insulin sensitivity. Okay. But primarily inositol is a component of the cell wall. There are different stereoisomers exist, and it has primarily as a second messenger improves the hormone signaling inside the cell. That is what it is doing. Okay. And you have two different isomers commonly used, the myoinositol and D-Myoinositol. Okay. Now both of them at the face of it are inositols, but they may have different actions. If you can see, the myoinositol actually upregulates aromatase, whereas the DCI inhibits the aromatase. Some of these actions, and insulin is the one, because all PCOS patients have hyperinsulinemia. Insulin converts more of myoinositol to DCI through stimulation of the epimerase. So important to understand this, because some of these variations are actually the key factor in the development of drugs, and you have different levels of the MI-DCA ratio in the plasma and ovary. Conventionally, it is 40:1 in the plasma, 100:1 in the ovary. And in PCOS patients, it has been shown that it is almost reduced to 0.2:1. So there is a lot of deficiency of myoinositol in the ovarian follicular fluid. That's why that has been promoted as one of the best molecule to improve the ovarian function. Some action on adipokines, the spectrum across the board, reproduction, metabolism, oncogenesis, CNS, mood, growth, everywhere it is there. Why I showed about the phenotypes is actually because of this. Do we actually consider giving inositol in all phenotypes of PCOS or not is a question mark. Why? Because, as I said, hyperandrogenism is not part of the spectrum D. Okay. So there it is actually possibly you may not get that much benefit if you are using the inositol than when compared with the other phenotypes. These are the initial meta-analysis which was published about 4-5 years back of myoinositol on the effects of PCOS, reduces the HOMA, the forest plot showing, and reduces the testosterone level. So some benefit as far as the androgen, as far as the metabolic parameters. Coming on to GDM, another important spectrum which when these ladies or girls conceive, one of the pilot trial from AIMS looked at 100 patients, again showed some benefit. Subsequent studies also showed that it may prevent actually the occurrence of GDM rather than treat the GDM. A meta-analysis which looked at, again it reduces the incidence of GDM and reduces the outcomes. There was no much data as far as the reduction in the birth weight of the babies are concerned, but definitely there is evidence to say that it is reducing the incidence of GDM. Comparison with metformin will always come whenever you speak with myoinositol. By and large, most of the outcomes, the studies have shown that they are comparable as far as these outcomes are concerned. And whether you combine these two, are you going to get an extra benefit? Not much of data, but yes, definitely it does help. So this is one of the meta-analysis which looked at individually, inositol, metformin, or a combination. How did they do? Again, there is some benefit to compare with myoinositol than when compared with the metformin. And these are the different spectrum of disorders in which it is seen. All metabolic disorders, hyperglycemia, hypertension. So you name any of these metabolic disorders, you have enough evidence to say that it is going to be slightly beneficial. This was meta-analysis published in last year, followed up with the evidence from the JCM just couple of months back. Now, most of the studies, the meta-analysis looked at about 4,000 odd patients of consuming about 36 odd RCTs. Where you have definite benefit is in the ovulation, there is no doubt about it. Metabolic benefits are not much than when compared with the metformin, but if you are using these two together, possibly you may get an extra benefit. And that is why it is a safe. You can read evidence suggests that benefits for some metabolic and potential benefit for the DCA for ovulation. Okay. Other outcomes, not much role. Okay. So to conclude, PCOS definitely is a condition that warrants multidisciplinary management. There is no doubt about it, because nobody can lay a hand that I am an expert on PCOS. Even everybody can treat it. Only thing is you need to know when that particular person requires a particular extra input from a particular person. So that is what is most important, because you will get the optimum outcomes in those patients. Another important thing, you need to educate about the insulin resistance. Lifestyle is the key factor underlying it, there is no doubt about it. Anything when you want to reduce the insulin resistance, metformin obviously we all use. Sometimes because of side effects or other things, you are trying to look at new other options beyond metformin, and that is where inositols come into play, and they have lot of promise in the PCOS as a supplement additive agent to the metformins, and possibly are safe during even pregnancy. But only thing is, evidence base is still limited. As of now, we still have about maximum 5,000, 6,000 odd patients data. That is why you are relying more on the meta-analysis rather than a good large scale RCTs on it. You may not get any RCTs in this because it is actually one of the off-label drugs, so you don't get any money by studying the inositol. So that is also important to understand, that you need to fall back on maybe the evidence or the physiology, whatever is available, before you consider that. And these studies will possibly help you in picking up the right combination for the right patient. I have finished here. Any questions or comments, I shall be happy to take.